We're very, very happy to be able to share with you some of the exciting research, but also the clinical work and the things that we believe are going to transform how medicine is practiced. So you who are at the forefront of this, I want to share with you a bit about the biology, the clinical evidence, and then also some case studies about this connection between infections, the immune system, and the brain. So we're going to go a little bit of biology. We're going to go a little bit about the case studies, but also a fair amount about how these things work and what it's going to actually do for the practice of medicine. So we're going to cover 4 topics. 1, the biological background of how infections can trigger various types of neurologic, psychiatric, and behavioral disorders. And why is it that certain infections trigger these immune-mediated neuropsychiatric disorders? You may be familiar with PANDAS and PANS, or maybe neurologic Lyme, obviously long COVID. And we're going to talk a little bit more about them and how they're related. And then we're going to work through some case studies of patients and the treatment categories that have shown clinical effectiveness in these immune-mediated disorders that are secondary to infections. And then finally, we'll talk about the biological targets and what we call the Autoimmune Brain Panel. If you've been with us before, it's formerly known as the Cunningham Panel, and how this can aid in the diagnosis and treatment of patients with these disorders. So let me start by just kind of making an observation. And we know that neurologic, psychiatric, and behavioral disorders are diagnosed principally by clinical symptoms, not etiology or cause. And I do believe in the future that that will change, because not all symptom manifestations are the result of the same etiology. So for instance, a patient that might be experiencing motor or vocal tics for more than 12 months, it's the DSM-5 identification, or at least the description of Tourette's. So if you look at many of these other disorders, they are diagnosed and classified by symptoms. Whereas we do know that many of these symptom presentations have a different underlying biology or underlying different etiology, because they have varying responses to treatment. And with that understanding, we enter the picture of inflammation, and more information is being understood about inflammation and the immune system that underlies the inflammatory process. But there is a difference between acute and chronic inflammation. Acute inflammation is vital to our health. So when we get infections, the acuity of the inflammation is what helps us, say, like in a flu viral infection, or many other infections. But when we see chronic inflammation, many of these chronic inflammation pathways can lead to various different kinds of things, including autoimmune disease and neurologic disease. What we want to talk about here is infections, for instance, strep, Borrelia babezia, Bartonella, Mycoplasma, and SARS-CoV-2, for a few examples. We know that there are associations with neurologic and psychiatric symptoms, even cardiovascular symptoms in some patients, pain, fatigue, cognitive and brain fog symptoms. And we also are aware that often they can be direct effects from the infectious agents. But what we want to talk about here is the indirect effect of the immune system dysfunction, because it impacts the treatment decisions. And we believe that the indirect effect is what really contributes to the chronicity of these disorders. So that brings us to the question, can infections trigger an autoimmune response that leads to neuropsychiatric disorders? Well, there's a really wonderful study that was conducted in Denmark and was published in March of 2019 in the Journal of American Medical Association Psychiatry. There was over 1 million patients that were followed from birth to age 18. And they followed the histories, and they looked that if any one of those individuals were hospitalized for a severe infection, what they noticed was that the risk of developing a mental disorder increased by more than 80% for the diagnosis of schizophrenia, autism, OCD, ADD, ADHD, personality and behavioral disorders, ODD, and tic disorders. And so the editors in that journal asked how could exposures to infections affect the brain mechanistically to give rise to mental disorders. They said circulating autoantibodies that enter the brain via compromised blood-brain barrier and bind to neurotransmitter receptors is a potential explanation. This mechanism has been proposed in PANDAS and other mental disorders. So you may be familiar with PANDAS or PANS, the term PANDAS and PANS, and a large portion of neuropsychiatric disorders are caused by an infection-triggered autoimmune dysfunction. So there is a growing recognition in the literature of the connection between infections, the immune system, and neurologic and psychiatric and behavioral disorders. And what you can see here is these antineuronal antibodies can impact brain function. And as you can see, there are other factors that are involved, including, we mentioned chronic inflammation, the microbiome, and various T and B cell dysregulation. So long COVID has shown us the effect of a virus can trigger the immune system to be directed against parts of the brain, parts of the heart, parts of the lung, blood vessels, and other organs. And we call that long COVID today, or now PASC, or post-acute sequelae of SARS-CoV-2 infection. So because the world is beginning to really realize that the chronic disorders that have an infectious trigger also have a resulting immune-mediated component that's triggered against and directed against many of these parts of the body, many of the treatments are anti-inflammatory, immune modulatory, and of course, anti-infectives. So if we think about how does this occur biologically, as we all know, everyone gets various types of infections. That is not new. And we also know that everybody produces antibodies that recognize or direct to parts of these infectious organisms, or what we call epitopes. But what does happen that's different in only certain individuals is that the antibodies that they produce are directed against a part of the organism that looks like a part of our body. And that's what's known as the process of molecular mimicry. And what we think about this is friendly fire in the wartime, where you can't tell the difference between the good troops and the enemy troops, and you begin exerting these destructive forces, in this case, against our own self. What transpires is the manifestation of these various neurologic, psychiatric, and behavioral symptoms because the interference of what we'll talk about, certain types of neurologic receptors in the brain. The standard of care is to place patients on symptomatic medications, which for a good portion of patients, these are helpful. But for the patients whose underlying root cause is an immune-mediated dysfunction, they are treatment resistant. In fact, often what you'll find is that these patients may even worsen on many of these treatments. But when the patients are properly identified as to the underlying root, these immune modulators, anti-infectives, anti-inflammatory agents are very effective. In fact, we can and do see many remarkable recoveries, sometimes after decades of suffering. So the mechanism of these antineuronal antibodies interfering with receptors is quite common because there are many. Some of them you may be familiar with, or some of them get more in the news, like stiff person syndrome and with Celine Dion, and many of the things like brain on fire, the NMDAR receptor with Susanna Calahan, and the book and the movie Brain on Fire. But what happens is that these antibodies cross the blood-brain barrier, as was mentioned in the JAMA article, interfere with the neurologic receptors in the brain, and in particular, what we're going to talk about those that interfere and bind to the dopamine D1 or D2 receptor, the lysoganglioside receptor, intracellular tubulin, and those that activate an enzyme called CAM kinase 2. And we'll talk a little bit more about why that's important later. So some studies have shown that in children that have sudden onset of OCD and associated inflammation in the brain, that the caudate, the putamen, and the globus pallidus, all of which are elevated on average overall, whereas not in the thalamus, which is not a part of the basal ganglia, show inflammation. And often inflammation is one of the components that does bring on and elicit many of these symptoms. Why is that? Well, the basal ganglia is responsible for things like voluntary motor control, the procedural learning process, and as well as cognitive functions and emotional functions and eye movement. And therefore, you can see when you see choreiform movements, you see brain fog, and you see learning problems, you see rage, anxiety, different types in mydriasis. You can see how they're connected to an effect on the basal ganglia in the brain. Now let's move to the nomenclature for a second. If you're familiar with PANDAS, you know that it stands for pediatric autoimmune neuropsychiatric disorder associated with a streptococcal infection. However, we also know that other microbes can trigger these types of almost identical, if not identical, similar symptoms. There is the belief that environmental and other biological factors can do that. So we now have infectious triggers, not just strep, but also non-infectious triggers. And this is what brought about the new term, or relatively new term, PANS, which stands for pediatric acute onset neuropsychiatric syndromes, and leaves off the infectious agent or the organism or the environmental or biological factors. The challenge is if that you're not a child or an adolescent, you can experience the same symptoms, but you don't have PANS or PANDAS. Well, there are other acronyms that have come across, like ANDAL, often called adult neuropsychiatric disorder associated with Lyme, or autoimmune neuropsychiatric disorder associated with Lyme, in an attempt to bring in or remove age. But if you look at this in a bigger perspective, these basically are talking about similar things. An autoimmune encephalopathy, or an inflammation or some type of disorder of the brain that's secondary to an infection, or in some cases, you'll see the term basal ganglia encephalitis. Now, often there's a connotation and a denotation. The connotation with encephalitis tends to be that this is a direct effect of, let's say, a virus or a bacteria. In these cases, it's not. The actual real denotation or the definition is it's just an inflammation of the brain. So what we're talking about is immune dysfunction that's resulting in neuropsychiatric and behavioral symptoms that are triggered by an infection. Well, lo and behold, autoimmune neuropsychiatric disorders triggered by infections aren't new. If you go back to the 1600s, which used to be known as St. Vitus's dance, you would see these abnormal movements, mostly in children, loss of fine motor control, loss of emotional control. And in 1686, Thomas Sydenham described what he calls chorea minor. And in the 1800s, Sir William Osler described these bizarre and percipitive behaviors in children with chorea minor that included OCD and symptoms of Sydenham chorea. Now, we don't see Sydenham chorea as much in the United States and other countries. It's still more prevalent. But acute rheumatic fever is caused by strep, but Sydenham chorea is the clinical manifestation or the neurologic manifestation of acute rheumatic fever in about maybe a third to a quarter of those patients with acute rheumatic fever. The treatment is penicillin, and you're trying to get rid of the underlying organisms that's triggering these autoimmune antibodies. So, in a simplistic way, the challenge is never to think outside the box, but in order to be able to address these chronic disorders and chronicity of these different conditions, you need to look at what are the underlying root triggers that are causing this. So let's move to the question to why do certain infections trigger immune-mediated neuropsychiatric disorders such as PANDAS and PANS, neurologic Lyme, and long COVID. There's an observation that we've seen and many have seen is that there are frequently certain infections that are associated with these autoimmune encephalopathies. One obviously is strep, which is where PANDAS came from, the term, but influenza A, varicella zoster, mycoplasma, Borrelia or Lyme, Babesia, Bartonella, Coxsackie, and several others, including SARS-CoV-2. And one of the reasons is there a sequence homology in a part of these organisms to parts of the brain in which we're going to talk about. So what is molecular mimicry? Well, it's just the process when a sequence looks like another, and a sequence of peptides, in this case, result in activating T or B cells. So there's only 20 letters of the protein alphabet that we as humans use, but they are ubiquitous in other organisms as far as the use of them for proteins. And therefore, at some point in there is an identical sequence of whether it be 5, 6, 7, 8, 9, 10 different peptides. The challenge is the body is not supposed to make antibodies against those portions. And we won't go through that, but through various types of ways our immune system screens for those, they're not usually made in the vast majority of people. However, if an antibody is made against one of those, what we call epitopes, and let's say it's on a bacteria, we do know that what happens is it elicits a B cell production, the clonal expansion of them, and then the development of what we call memory B cells. And these memory B cells are, what we're trying to get to for vaccinations and immunizations. But when we're talking about an autoimmune condition, it's what creates the longevity of these different types of disorders. So we take our example again, and we look at let's say a neuron that has the same identical sequence, that if an antibody is made to that sequence, it will cross-react, in this case, with a part of a neuron. So we're going to talk about a few of these different neuronal targets in the brain. Published studies have shown that in strep, that there is molecular mimicry between the M protein, which there's 100 different serotypes of that, and the heart valve. Hence, we have rheumatic heart disease against the basal ganglia. We have Sydenham chorea, and we see joint and connective tissue pain and kidney function. So molecular mimicry is just really the inability to tell the difference between self and non-self, and the confusion or the misdirection of where we're directing our antibodies. So let's now move to some case studies on patients and the different types of treatments that have shown the effectiveness in these patients. This one happens to be an 8-year-old girl that had numerous psychiatric symptoms. She had a sudden onset of OCD, vocal tics, poor concentration, sensory abnormalities, emotional ability, and even dysgraphia and urinary and sleep problems, which often can accompany that. This one was caught early, actually. This was sudden. This was not too soon after the onset of these symptoms. She was tested, and we found that there were 2 autoantibodies that were above normal elevation, and that was lysoganglioside and antibodies against tubulin. This was a relapsing remitting illness. She was diagnosed with anxiety, OCD. However, her lab tests for ASO and DNASB were normal, whereas her medical history, she had 2 recent streptococcal infections, sore throat, sinus pain, cough, and a history of frequent ear infections, sinus infections, etc. In addition, her family histories show that they were positive for mycoplasma, autoimmune disorders, allergies, and other bacterial and viral infections. So the patient, because he was caught early and this case was presumed to be a bacterial infection, she was treated with 1 course of azithromycin, rapid symptom improvement. We were able to test her afterwards, after she returned to baseline within 2 to 3 days of treatment. And as you can see, her anti-lysoganglioside and anti-tubulin antibodies returned to normal. So this is a 16-year-old young girl who's had severe OCD, tics, and even restricted food intake. And so this restricted food intake really in these cases are thought of more as an OCD, fear of food contamination, a fear of choking, more a phobia around food rather than a body dysmorphia identity disorder. So she had tics, choreiform movement, poor concentration, cognitive and academic decline in a 16-year-old, sensory abnormalities. And the bad thing about this child was the behavior prompted 6 calls to the local police for assistance. And often, sometimes this can be the case. We did test her. She had 1 elevation, and this was the elevation in activation of the calmodulin protein cam kinase. This is particularly an enzyme that's in the brain that actually is responsible for the release of epinephrine, norepinephrine, dopamine, GABA, many other neurotransmitters. So her illness was relapsing remitting with 3 episodes and an increase of her symptoms with another strep exposure. She was diagnosed with autoimmune disease, not otherwise specified, post-infectious encephalitis, and she was positive for a Lyme Western blot. She also had elevated mycoplasma and Coxsackie virus titers. And this is one thing that we do find is that usually in many cases there are multiple infections, because if you think about it, if the immune system is dysfunctional, these opportunistic infections can occur and take hold, but they're also eliciting and triggering the immune system to generate these antibodies. The family history was interesting. Autoimmune disorders, rheumatic fever, and actually these siblings had PANDAS. So the treatment in this case was to remove the antibodies through plasmapheresis, add IVIG, and just dramatic symptom improvement. They were treated for low-dose Zoloft and Abilify, and often these maintenance is low dose because regular dosages, patients actually get worse, and significant improvement in her symptoms. You can see her CAM kinase level return to normal. A 20-year-old young girl with OCD and neuropsychiatric symptoms, gradual onset. PANDAS is a requirement for acuity of onset, but that doesn't mean that gradual, or let's say maybe a symptom that occurs, but occurs over time, may not still fit the biological course, but strictly from a diagnostic perspective, they can't have PANDAS or PANS. And because of the age of the child, couldn't either. So separation anxiety, developmental regression, urinary frequency. We tested her. She had antibodies against the dopamine D2 receptor and an elevation to the calmodulin cam kinase enzyme. She also had frequent relapsing and remitting flares and peripheral neuropathy. As you can see, many of these other types of symptoms, migraine, they did test her. She was concluded to have Lyme and a disorder of the autonomic nervous system. So she was positive for strep, Borrelia, Babesia, Mycoplasma, Epstein-Barr, herpes virus. And one of the things about the autonomic nervous system is that we see when the elevation of calmodulin CAM kinase is high, you do see an association with the autonomic nervous system being activated, such as fight or flight, easily startled, various types of things that are associated with autonomic nervous system activation. The patient had frequent strep infections since childhood. And in this cases, sometimes patients will have low IgG, dental infections. Family history was positive for autoimmune disease. This one required 4 courses of rituximab, which they added ozone treatments to this patient. And in this case, significant reduction in all of her symptoms. We retested her. Her dopamine D2 levels returned to normal. The calmodulin CAM-case activation returned to normal. One last one I'll share with you because this is a little different. This was a published study by Dr. Bernstein and his colleagues, Dr. Barkman, of a patient, a 15-year-old girl who had been diagnosed and treated unsuccessfully for schizophrenia, psychosis, anxiety, depression, and they were cycling her in and out of treatment facilities. He published the results here. She had elevations against dopamine D1, D2, lysoganglioside, and tubulin at the time of her diagnosis, or at the time that he took over the care for her. He then ordered 1 course of plasmapheresis, which was administered, and the patient had complete resolution of her psychiatric OCD and anxiety symptoms. They had weaned her off of olanzapine, and she resumed her normal activities, including tennis, within 2 weeks after plasmapheresis. And the response, he said, was sustained for now over 6 months, consistent with previous studies. We did contact him after this was published. We retrieved, and he gave us a specimen for her. We tested her, and all of these antibody levels returned to normal. So let me summarize this by showing we find that the reason it's important to identify all 5 of these targets is because different symptoms are associated with different targets or interference with different targets. So when patients have antibodies directed against the dopamine D1 receptor, we tend to see frequently presentations of various psychiatric symptoms, mood swings, depression, anxiety, irritability, aggression, delusion, and in some cases, psychosis. When antibodies are directed against the dopamine D2 receptor, we see more frequently some level of some type of movement disorder. It could be choreiform movement, such as what's seen really with Sydenham's chorea, or maybe even a diagnosis of ADHD because they can't hold still, and possibly even Parkinson's. When antibodies are identified to lysoganglioside, which is basically the myelin sheath around the nerve cells, patients can frequently complain of joint connective tissue pain. And when we see antibodies against tubulin, which is intracellular protein, it's heavily concentrated in the brain, which is where we actually get isolated the tubulin to run our assays. We see complaints of what people might think of as brain fog, cognitive complaints, OCD, food phobias, other types of phobias around clothing and intrusive thoughts. And as mentioned, when we see the activation of this enzyme called CAM kinase 2, we see things associated with the activation of the sympathetic nervous system. CAM kinase is heavily concentrated in the neuronal cells of the brain, and that we see symptomatic activation like fight or flight behavior, maybe separation anxiety, maybe easily startled, bedwetting, sensory sensitivities, and even mydriasis. One thing that kind of is interesting that we've seen is that often when this is elevated, it does suggest that there are active infections that haven't yet been treated in the patient. Now, this is not a test for infections, but it does make you want to look at and check for, is the patient suffering from infections that have not been identified yet. If you're interested, we can send you many published research papers about the different biomarkers and their use. So just let us know, we can send those to you. But it is important that we see precision medicine in neurologic, psychiatric, and behavioral disorders because patients can present with similar symptoms. And we do know that certain patients, between 20 to 60%, depending upon the diagnosis category, these symptomatic treatments are not effective for them. And often they get tried in other types of medications for different types of antidepressants, anti-anxiety drugs, but often it does make it worse. And so this is why it's important to be able to identify those patients that are immune mediated in nature, because their treatment can be changed to anti-inflammatory agents and immune modulators, as was shown in these studies. And then those patients who are not positive can then go on to be treated with psychiatric meds with a higher degree of certainty that they would respond to some type of combination or some type of symptomatic treatment. And last, we have literally hundreds of patient stories, which you can go to our website and see different cases. This was Grace, who was actually diagnosed with a mental disorder at age 8. Wanting to kill herself, oppositional defiance, ADHD, OCD. The parents emptied out their 401k twice and they had no answers. They contacted us. She was tested, was positive, and was treated effectively. Not too long ago, her mother sent us this picture of her completely well, back to normal life and on the cheer team. This is Adam, who also was diagnosed with ADHD, and they also thought he may even have autism. They were considering institutionalizing him. They found out about us, contacted us. We tested him. He was treated and recovered. And then not too long ago, his mother sent us this picture of him running cross country, saying recovery is possible. He's 10,000 times better. So here's some commonalities of patients that we see that are positive for these anti-neuronal antibodies and CAM activation in the autoimmune brain panel. One is that they tend to be treatment resistant to standard neuropsychiatric drugs. Now, ideally, we would like to see them tested first before months and sometimes years on a host of different medications, but typically what we'll find is when they come to us, they've seen between 5 to 15 different clinicians, and they're still resistant to standard neuropsychiatric drugs. You can also see a frequency of infections, and sometimes these infections are subclinical. They may have a diagnosis of Lyme or post-treatment Lyme. And as you saw, family history of autoimmune disorders is not uncommon. And the sudden or acuity of onset of these neuropsychiatric symptoms sometimes is an indicator. And then sudden or rapid onset of OCD, including restrictive eating disorders and motor, vocal tics, and choreiform movements, the presentation of anxiety, rage, separation anxiety, emotional lability, and the waxing and waning or the different types of mood swings here, depression, developmental behavioral regression. And in maybe about a third of patients, you can see these dilated pupils in urinary frequency, bedwetting, and this relapsing remitting course. We have worked with a pediatric neurologist who tests and identifies and treats literally hundreds of patients like this. And she says, you have to ask them, but they all have suicidal ideation. In fact, I just got off a call just about an hour before we joined here, a physician whose son took his own life at age 27. And he was not aware of the infection-induced autoimmune neuropsychiatric disorders. And he said for the past 3 years before he took his own life, he was saying he didn't want to live anymore if this wasn't going to get any better. And so there are sad stories of many of these, which is why it's important to recognize that not everything that's going on will be verbalized, but it's important to get a very accurate and rapid diagnosis. Obviously, PANDAS and PANS is one. So here's a few takeaways. It's very important to obtain a thorough medical history because often you can see these things in a medical history. And unfortunately, I know in the standard practice, you really don't have a lot of time to do that. But it is important to be able to get a thorough medical history because gradual onset of symptoms could be sudden onset many years ago, but forgotten. Of course, relapsing, remitting, family histories of these different autoimmune disorders, restrictive eating, weight loss, not the classic anorexia, obsessional fears, choreiform movements. One of our clinicians who says the practice is to have them hold their hands out, close their eyes, and if they can't hold their fingers still and they start seeing these piano playing finger movements, this is the choreiform movement in which they can't keep their fingers still. Dysgraphia, tics, mydriasis, and then of course some labs you can look for strep, but again, remember it's not always strep. Sometimes it's in the family too, if it is. ANA, although it's non-specific, sometimes it's positive in more than 50% of these patients. Often look for occult infections. And of course, what we would say is that it'd be great to be able to identify first, is this autoimmune, before you move on to other types of testing. So in an overview of this, the takeaways are identify and treat all the infections. You want to rule out other causes, but you also then want to treat the inflammation and the pathway of the inflammatory inflammation, including then treating any immune dysfunction, any immune dysregulation, and then provide, as some cases here, symptomatic relief. And that falls into treating the three I's: treat the infections, treat the inflammation, treat the immune dysfunction, and you can see these patients do recover. And so, there's many things that occur and can occur, metabolic dysfunction, gut dysbiosis, Herxheimer reactions, because often when you're killing these infections, the die-off occurs, and it might look like they're getting worse, but in reality, they're clearing these infections, and these toxins are actually being now released into the blood system. If you're looking for some medical guidance, that is a good way to follow the Journal of Child and Adolescent Psychopharmacology in 2017, and I think even 2015, has a series of PANDAS best practices. These can be followed and very similar, or at least giving you good guidance as to treatment for anti-inflammatory, immune modulatory drugs. And the PANDAS Physician Network is a wealth of information. Again, PANDAS being a medical model for many of these. So how do you order if you're interested in testing? Some of you have already done this. We do require that a healthcare provider provide the panel order. It is done online. There will be the collection of 2 red top blood tubes, and I say red top because currently red top does not have any excipients in it, and many of the excipients and other tubes can interfere with these assays and provide erroneous results. The cost of the panel is $995. We ask for a half of that, a deposit up front. However, we do bill insurance, and about half of the patients get insurance reimbursement. We do have payment plans and way to help patients. They will come to us FedEx overnight, and then they come to our laboratory here, which is CLIA COLA accredited, and we perform all 5 brain target assays. It will take somewhere between 2 to 3 weeks. I know that's a long time. It used to take 6 to 8 weeks. We're trying to get this down to below a week. But because of the complexity of these assays and the radioisotopes that we use, it does take that long. You will be notified when the report is ready. The report will be uploaded. We will courteously bill the patient's medical insurance, And we provide free online report consultation and in-services, which if you're interested, please contact us. We can provide you and your office with webinars for in-service on the Autoimmune Brain Panel, again, formerly known as the Cunningham Panel. We'll provide consultative services to you on your patient laboratory results. You should receive an email saying that that's available if you're interested, or you can email medical relations at molecular.com. We have a staff nurse, of which Amy Cross here, who is our moderator here, and another nurse on staff that you can reach out to. We also have resources for you and publications and videos on our website. If your patients have questions about the panel or the blood drawing station, have them call our office, and that number is 405-239-5250. If they have questions about insurance coverage or payment plans, call our office at the same number. And we have free downloadable, or you can request hard copy brochures if you want to give to your patients or leave in your office so you don't have to explain this to all of them. So what we're trying to do is to make it easy to be able to help educate your patients, as well as those who need and desperately need help, because as mentioned, that many of these patients suffer for long periods of time. But we're thankful to you because we know that you're changing how medicine is practiced for these immune-mediated inflammatory disorders, and through it, bring hope and healing to these hurting families.
Thank you, Dr. Shimasaki. We have 2 questions from our friend Suzanne across the pond. Suzanne asks, have we seen good improvements with non-drug treatments?
Yes, and if you're referring to drug treatment, meaning FDA-approved types of medications, there is more and more usage of what we'll call maybe natural treatments and different types of support. So, for instance, I mentioned those 3 categories: infection, inflammation, immune. The FDA-approved drugs aren't the only ones that impact those 3 categories. There are natural products, there are other supplements that actually do. But certainly, we know many clinicians who use a combination and many who kind of use predominantly those. So again, remembering you're wanting to treat the infection, treat the immune system, and treat the inflammation. If you can do that, you're going to see an improvement in the patient's symptoms.
Suzanne has a second question. Do patients relapse often after plasmapheresis? And do infections need to be silenced first?
No, that's a really, really good question. I don't, usually I'll put up this 2-tack theory that says if you're sitting on 2 tacks, removing 1 tack doesn't remove 50% of the symptoms. So you do have to treat the infections. However, plasmapheresis, as you know, will immediately remove those antibodies. So patients will typically feel much better immediately, and it'll sustain for a while. If they have an underlying infection that hasn't been treated, those immune cells and the memory B cells will continue to generate those antibodies. And then once they've built up a high enough level, you can see the relapsing. Let's say they don't have the memory B cells, let's say the infections were cleared. There are some instances where another infection will re-stimulate and trigger that, but usually because they know what they're looking for, they can get it taken care of very quickly. But it's a great question because you do need to treat the underlying infections as well as the immune system and inflammation.
Thank you. Third question. Where do you think the main opposition comes from in the UK to treating autoimmune brain inflammation?
Yeah, that's a really great question and a difficult and challenging one. We have partners with the AONM who are working very diligently to help change that. I think you might look at this as compared to the United States, it's still an area that is gaining acceptance, but still not fully understood by the broader population. We might say that if you look at in the UK, maybe it's 15, 20 years earlier than where we were. Some of it can be due to the differences in who pays for and how healthcare costs are allocated to which. So there's a lot of private pay, self-pay insurance in the United States, and we're kind of used to getting whatever and whenever and however and how much whatever it costs if we have good insurance or if we can afford it. I do believe through the efforts in the UK and what you're doing, and many of that in Parliament and many with your prescribers and showing people get well, that is going to change. But it is an area which we all need to find ways to help educate and demonstrate scientifically and medically that this is a condition. Long COVID is helping in one sense, if we can say that word, helping, because there's lots of people suffering from long COVID, and it's a very similar medical model.
Because it is an autoimmune condition, does the patient need to take care of their immune system for life?
So let me kind of define again, connotation and denotation. The connotation, when we think of an autoimmune dysfunction, we kind of think of lupus and MS that are right now believed to be sort of chronic lifelong, although there are better therapies coming along. It is an immune dysfunction, an immune dysregulation, and we do see lots and lots of patients who go on that are treated effectively that don't have future problems. Some of them have reactivation with the stimulus of something, and they get treated right away, either for the underlying infection or maybe an anti-inflammatory. I think it's important to be aware that that could, so that you can take care of it and get it treated rapidly. It's when it goes untreated for long periods of time that you see this problem. But it could be a possibility that you should, I would say, be vigilant. But we have lots and lots of no success stories of children who experienced it, who are now graduated. Some of them are what we'll call rocket scientists, really rocket scientists, going in and doing great things. So it is something to be aware of, that the possible propensity, but I would not consider it that you have to somewhat treat that all the time, unless there's some kind of underlying metabolic disorder that's making them more susceptible.
Do you know any cases where dental or tonsil treatments were part of the treatment?
Yes, there definitely is. And Dr. John Harley, who is over in Washington, D.C., is one who has done a fair amount of studies showing that if antibiotics don't clear these infections, that often you'll see the tonsillectomy and adenectomy. And he has specific ways to do this, because you can find a lot of infections being harbored in these parts of the body. And so there is evidence that that is and has occurred. You also need to look at thinking about, do you treat it first? But, it might not be the first line that you look for, but if you don't see improvement after, treating known infections, then that is one of those things that actually has been documented and published, showing that it can be one of the problems.
Thank you. Melissa asks, How are we getting rituximab and IVIG covered by insurance? She says we struggle to get those treatments for PANDAS patients.
Yes, and this is something that we have found helpful when we can provide testing results that show there's autoantibodies against specific targets. It falls into an area that helps support that. Now, as you know, there's an art in some cases of getting reimbursement. A lot of it is persistence and perseverance. We partner with a group called Solio Health, whom we can put you in touch with, whom are very good at helping not only both the administration of it, but also getting it covered. So they have a great track record and they do know how to do that. And they're happy to help. So we do partner with them because it allows the ability to have a patient tested, use that in a way in which it would help justify the types of treatment, and then they can help also provide the treatment and the reimbursement.
Dr. Perry asks, I ordered my first panel this month. I am a pulmonologist and just took a good history. It was positive. I sent the results to the pediatrician and the review article that you had mentioned. She told the family this was a fluke and refused to treat the family. I was shocked. I got another pediatrician to care for this patient.
It
Any
is
experience, an add-on to that question, any experience with using low-dose naltrexone with these patients?
so unfortunately, this is something we wish were not happening. It does happen, and we've tried and worked with many of these who are sort of, hey, I believe what I believe, don't confuse me with any facts. So what we found is you do have to move on to those who are either open to understanding or learning, or someone who actually has treated these patients before and had success. We do believe, like the story of the Helicobacter pylori and the belief that bacteria don't cause peptic ulcers, that it takes sometimes decades for the mainstream medicine to adopt and recognize how an infection can be involved in different disorders. So the best answer is that was the right thing to do to move on, because often it's very difficult to convince someone of something. In fact, this was the case of he was an ER physician and an anesthesiologist whose son took his life. He had tested, the test was positive. He gave it to someone and they dismissed it. And then not too long after that, he took his life. And this is what we don't want to have happen, that an individual suffers. So your next question is low-dose naltrexone. And yes, low-dose naltrexone, talking really at a 0.5 milligram to 4 milligrams a day rather than the normal dosages, has a different mechanism of action. So that is actually known and seen to modulate the immune system and also provide some other effect that is not quite understood yet, but it does modulate the immune system. And the reason is it's got two what's called an enantiomers, and these are right and left-handed molecules, and they do different things. And so there is a lot of evidence and a lot of practitioners that work with patients that we test do see great results with low-dose naltrexone. Again, finding a clinician who can help and guide, and that's a great way because they all learned themselves at some point.
So thank you so much, Dr. Shimasaki. There are no further questions in the queue. We have about 3 more minutes before we have to end. So if there are any last minute questions, I am watching for those. Here is one. Will the lab results suggest what medication to give the patient?
So that's a great question that we are actually working on at the moment. So we have accumulated over 15,500 patients and clinical annotations, as well as these biorepository specimens. And we're beginning the work through a grant to be able to take all that data and be able to predict through algorithms which treatments would work most effectively and efficiently for different patients with these results. And so this won't be available like really soon. We're hoping in the next year or so that that would be. However, the key here is when a patient is positive, move them over to anti-infectives, immune modulatory agents, and anti-inflammatories. So that is something that we really hope will be done and to provide these treatment guidances through AI is everywhere. I don't know, you can't turn around and not see it, but it is working in medicine. And so one last comment, Amy, is we here work to do a lot of research and understanding in clinical medicine. If you have patients or you have cases that you find are difficult, call us, talk to us, but also it may be worth a study or maybe a case study or something we can partner with in helping to get that information through pre and post treatment testing, as I showed, and get that out into the medical literature. So if you have any of those cases or if you just need any help, we're always ready here to do that. That's the reason we started the company. So we appreciate all the work that you're doing out there at the front line.
I added in the chat box the name of the company that Dr. Shimasaki referenced regarding IVIG availability. I see that I have two misspellings because I'm controlling the dog with one hand and typing with the other. Thank you, everyone, so much for your participation today. We look forward to more webinars in the future, and we look forward to hearing any questions that come to mind after the webinar. Please let us know how we can help. Thank you. Thank you, Dr. Shimasaki.
Thank you, Amy, and thank you, everyone.